because part of the rush exam is doing the DVT study, or at least you would consider it. We'll start with the
Mm-hmm.
DVT study. That's okay.
Okay.
Let me just see if I can. It's just pulling it up still. I guess I'll ask you, have you ever done the DVT study, like point of care?
Yeah. Yeah. But then, yeah.
We've done
We
it
did
together.
practice last session when you have like the in the sim lab.
Yeah. Didn't we do one that was positive together one time? I feel like we were like scanning in the ER and we actually had a positive one.
I
Or
think we have one, I think, positive DVT study in the area.
yeah, I think we did. Okay. So I mean
Yeah.
it comes up. It's not like a totally uncommon thing
Yes,
to
I think.
find, when you're working clinically. Just get this keynote up here. Obviously there's, the idea is you could do the upper and the lower, or the lower extremity DVT. I think for our purposes we'll limit it to discussing lower extremity DVT.
Mm-hmm.
Um, just because, upper extremity DVT gets into a little more sort of complex
Mm-hmm.
kind of dynamic stuff. Are you able to see that, Afsal? The lower
Yes, I
extremity.
can see. Yeah.
Okay. Is it formatting is okay for you? Like that.
Yes, that's okay.
All right. Really simple. So the the indications for doing the lower extremity point of DVT are really the same as you would for ordering the formal study, with
Mm-hmm.
the difference that you need the answer sort of right away, right? You can imagine somebody who has like maybe an acute decompensation at the bedside where you wouldn't want to wait the 30 minutes, hour and a half before you get the formal study. And
Mm-hmm.
something I've been thinking about this study is that it is easy to do, it's easy to interpret, and the findings are very valuable. All those things are true, but for some reason, and I think I know why, we don't do this one a lot. It's like it's not something that we pull out of our tool bag, probably as much as we should. And I think
Mm-hmm.
that has to do with the fact that um, it's the prep that's difficult. Like actually performing the study is easy, but getting the patient undressed and in the right position is probably the heavy lift. And I'll talk about how I don't think that that's actually as big a deal as we make it out to be. But I just sort of like reframe this as like actually a very easy exam that you don't need to be intimidated by at all, and might really
Mm-hmm.
help. And oftentimes when you're at the bedside with an acutely decompensating patient, the ability to quickly say whether or not there's a lower extremity DVT could be really valuable.
Mm-hmm.
Particularly, maybe somebody just coded and you're trying to figure out, okay, could this potentially be a pulmonary embolism? Who's pushed up TPA. This is a pretty valuable test to have in your toolkit. The basic
Yeah.
binary question of this exam is yes or no. Are those deep veins of the leg compressible or not? So it's a binary exam, which also makes it really easy. So the probe of choice for this test is going to be the linear probe. In a patient with, thicker soft tissue, you could consider the curvilinear, although
Mm-hmm.
directing the pressure that you need for the compression ultrasound becomes more difficult the wider the footprint is. So I'd say that unless you absolutely can't see, don't have the depth necessary with a linear probe, I would really stick with the linear probe for this. And it's all about the preparation. And with this, you really just need to remove the patient's pants. Remove the patient's
Mm-hmm.
pants, do a little bit of an external rotation at the hip with a little bend at the knee, and you're basically there. I know a lot of patients, we see in the ER, this won't be as much of a problem upstairs, but they have like maybe sweatpants on or jeans, and there's really no way to do this with pants on. You got to get the patient at least a bit undressed. And so I think that maybe is the hurdle, that plus a little bit of like patient comfort and mobility. But you can leave the underwear on. All you need to do is be able to access the inguinal crease, and so you can sort of
Mm-hmm.
bring the boxers up, or the waistband of the underwear down, access the inguinal crease, and you're kind of off to the races. Now, this is a two-part exam, and so the first part is going to be accessing the inguinal crease and that sort of thigh, that sort of medial aspect of the thigh, just down to the bifurcation of the common femoral, and then you got to get behind the knee. So for the first part, we're going to get the inguinal crease to the sort of inner thigh. And the idea with compression ultrasound is that you're getting the vessels in their short axis, and you apply pressure. You apply pressure until the associated artery starts to compress slightly. And by that point, the vein should be collapsed completely, just physiologically. If you start to press on somebody's artery vein, and they're always associated when you're dealing with a deep vein by definition. You push enough on those two structures, the artery will start to deform, and by that point, the vein should be completely squished.
Mhm.
You do that when you sort of oriented yourself to where you are, you're in the right location. You compress, okay, it looks good. And then you basically walk down through a prescribed area and compress every 1 to 2 centimeters. And as long as you have compression through that area, good, negative study, easy peasy. So here's an example of somebody, they have an artery and a vein. They're applying enough pressure. You can see they're applying enough pressure so that the artery starts to deform. And by that point, the vein is totally gone. And this would be considered a negative study for this one spot. Here's an example of them. They're pushing. You can tell they're pushing because the artery is deforming, but this vein is not going anywhere. And in fact, once they compress, you can sort of start to see some echoes inside of the vein, indicating that okay, there's a little bit of clot there, and because there's echoes, maybe it's a little bit more of a chronic or subacute clot. Because as it turns out, the fresher the clot, the more anechoic it is. So it's easy to miss if you're not doing the compression ultrasonography. So this would be a positive study. The only other part of this exam is just to remind ourselves of some of the gross anatomy. And the relevant stuff is not too much. Basically, we're only going to start here at the area of the common femoral, where the saphenous vein drains in as a tributary to that. So this is basically where the inguinal crease is. We wouldn't really expect to be able to see the internal and external iliac veins during this exam. But the expectation is that in the inguinal crease, you're going to find the common femoral vein where the saphenous vein is draining in. And this is the relationship almost always anatomically. You remember that we have the artery, really goes nerve, artery, vein, that kind of naval mnemonic or venous towards the penis. Medial to the common femoral vein, the saphenous vein drains in from the sort of superior medial aspect. Once you find that relationship, artery, vein, and then this more superficial saphenous vein draining in, you know you're in a location to start this study, right? This is usually around the inguinal crease. Compress and make sure that the common femoral and the saphenous vein are collapsing completely. And then you're kind of off to the races. What you'll do then is just follow the common femoral vein down until it bifurcates into what they call the deep femoral vein and just the femoral vein. They
Mhm.
used to call this the superficial femoral vein, but it led to some confusion and some mismanagement. So it's now just called the femoral vein. And this is the sort of idea. You're getting a little bit deeper into the soft tissues here. And by the time that the common femoral vein bifurcates into the deep and the femoral vein, you basically have done enough to satisfy the first portion of this POCUS exam.
Mhm.
Here they have the bifurcation. They have it a little mislabeled here. SFV would be superficial femoral vein. That's what they used to call it, and then the deep femoral vein. But you can see that it's bifurcated. Both are adequately compressing. They're pushing hard enough so that the arteries started to compress. So they're good. They're satisfied. At that point, you take the probe totally off the leg. You're not having to chase that femoral vein down, and you just basically go from behind the knee. We've done this before. So you go from behind the knee, and I think probably the easiest way to do this, you can keep the patient frog leg, but if they're able to turn on their side, it makes it much easier to get into that popliteal fossa. So, regel your probe, and I like how he's doing it in this picture, that's why I included it. He's got his other hand sort of stabilizing the patella on the other side, something that he can push up against, and that just gives him something so where he can apply enough pressure to compress that popliteal vein. What you run into sometimes in the popliteal fossa is that the hamstring tendons are a little bit in your way and they're a little tight, and they sort of hold you back from putting as much pressure as you'd like. So stabilizing with your other hand can be pretty valuable. Otherwise, you just kind of start pushing the patient's leg off the bed. So this is a nice example of how to do this. And you could do either, obviously he has her on her left side, you could do top or bottom, easy peasy. Once you get into the popliteal fossa, you're looking for the artery vein association. Classically, it's like a double scoop ice cream, the vein on top of the artery. They say pop on top, so the vein on top of the artery. Because you're coming from the posterior, technically the vein is posterior to the artery, but it appears on top because you're coming from the back. And you, same as with the other sort of part of the study, you just push enough so that the artery compresses, and by then the vein should be totally collapsed. Basically, at that point, you're following the popliteal vein down until it trifurcates. So the common femoral bifurcates and the popliteal trifurcates. And there's really no need to try to suss out which of these veins is the anterior or posterior tibial, which is the perineal, just to see that it trifurcates and that all three of these branches compress. Adequate, just like that. That's the whole study, really. A couple tips with this is obviously the vein, and I've said this a few times, the vein really should be fully compressed before the artery starts to compress at all in someone with a normal blood pressure. It's sometimes valuable if you're getting a little mixed up about your anatomy and location to use color to try to orient yourself. And so you can put color Doppler on the artery and the vein, and obviously the pulsatile one, the one that's showing pulsatile color flow, will be the artery. Augmentation is something that only veins do, and that's the idea that if you, and I think maybe we did this as well, if you squeeze the calf distal to a vein and have color, you'll see a big rush of color coming through the vein because you sort of you're causing that sort of pneumonic compression and rush of blood going back. If you think you have a positive study, or if you're not sure what structure you're looking at, I would just encourage you to scan fully through. Sometimes a cyst or a lymph node or hematoma or even an abscess could look like a large vein or a vascular structure. And the only way to sort of convince yourself otherwise would be to scan all the way through. The classic, I think, would be a lymph node looking like a non-compressible vein. Pretty common thing you get mixed up. It won't compress, but if you fan all the way through the whole structure, you'll see the kind of blind ends the way a vein never would. And just as another tip, I sort of alluded to this, but deep veins, by definition, are always accompanied by an artery. So if you're looking at a vein and you think it's a deep vein, you're compressing it, but there's no artery associated, then you're probably mixed up to your location, right? So that's just sort of a general principle. Here's an example of somebody putting color flow to sort of define the anatomy. See the pulsatility of the artery and some sort of slower laminar flow of the vein. Here's somebody, you see pulsatility of the artery, and then they're squeezing the calf distal, and you get this nice rush of, this is what it looks like when you get augmentation. Nice rush of blood when you squeeze the calf, just like that. This is an example of a cyst. This is a Baker's cyst in the back of the knee. This would probably compress if you pushed hard enough, but it would take quite a bit of pressure, and you'd be mixing up. You could tell it's a Baker's cyst. It kind of reaches down into the joint. Here's an example of a lymph node. You see how it blind ends. Obviously, it's not compressible, but also, not a vein. A couple other sort of thoughts here. This study can be beneficial not just by identifying DVTs, but 15% of patients who we initially suspect having DVTs, you're going to find an alternate diagnosis, and you're going to find it by doing this study. So you might find the Baker's cyst, or an effusion, or see cellulitis characterized by palpable stoning. So still, I think a valuable study to do in those cases. The other idea is that I think I mentioned this, but chronic DVTs, the more chronic they are, the brighter they tend to be, and they have kind of this sort of ragged edged appearance, more so than acute DVTs, which would be a little more smooth and a little darker. When they've been chronic and they start to recanalize, they'll recanalize centrally, and so you see some thrombus in the sort of outer part of the chronic DVTs. And you'll see in like the formal reads, they'll sort of mention these things in the formal reads of the DVT studies. Also, if you're having sort of mixed up about this, you could get a sagittal view and just sort of look and see what you have, maybe central canalization of a chronic DVT. When you're doing this at the bedside, it's very simple what you need minimum views wise. Dynamic compression of the common femoral vein down to the point where it bifurcates, and then compression of the popliteal vein. There's really no need to apply color or pulse wave, as you'll sometimes see in the formal reads. For our purposes, just get that common femoral vein, squish, squish, squish down to the bifurcation. Okay, we're good. And the popliteal vein. When you're doing the common femoral vein, try to get it where there's the inflow of that saphenous vein, that great saphenous vein. And I guess just as a plug for best practice, if you do identify either point of care or the formal study, a clot in the proximal saphenous, the recommendation is actually to treat that as a DVT, even though it is technically a superficial vein thrombosis. The risk of propagation into the deep system in that case is pretty high. It's only one of a couple superficial veins in the body where they recommend actual anticoagulation. The other one I'm aware of is the internal jugular vein. They say is probably unacceptably high risk to propagate into the deep system, and so you would probably superficial. You probably would treat that too. External jugular. All right, so that's the whole DVT lecture. Any questions on that?
Okay. No question. Yeah. Thanks.
Okay, cool. So this other one is going to be a little more kind of interactive. Let me just see if I can pull it up. I got it downloaded Are you familiar at all with the RUSH protocol? There's all these different sort of acronyms and protocols in POCUS. Have you ever heard of this RUSH protocol?
Rush, not sure, yeah, about the rest.
Okay, right. Okay, so it just sort of puts together the idea with the RUSH protocol is it puts together um, a few of the studies we've become familiar with in a critical care setting to try to identify the source of hypotension in a sick patient. So
Oh,
you're
okay.
going through a sort of algorithmic approach to ultrasounding a patient in whom you don't know the source of their shock, basically. Let me just see if I can pull up this window. Can you see the RUSH lecture here, Afsal? We got it pulled up here.
I can see my picture.
Okay. And what a fine picture it is. Hold on. Let me see if I can. If I put this in a separate window, maybe.
I can see now.
Okay, great. Okay, great. Still got it?
Mhm.
So the RUSH basically stands for rapid ultrasound for shock and hypotension. And the idea is that you are sort of quickly scanning through several different organ systems in order to identify the source of the hypotension. And the way I think that they've laid it out is pretty clever. The idea is the source of the shock is going to be pump related, meaning heart related, tank related, meaning you're sort of having a volume related issue, or pipes related, so big vein or big artery sort of catastrophe that could be contributing. Um, this is a nice little sort of infographic from these Northampton guys. So pump, we'll start there. When you have a patient in front of you who's acutely hypotensive, shocky, sort of crashing, there's a few different, I think, possibilities that you could get from your echo. Obviously, ejection fraction, low, normal, or high. In a patient who's hypotensive in front of you with a low ejection fraction, then the idea of cardiogenic shock kind of, I think, goes way up on the differential, and that's a very sick patient. It also could be the end state of several other causes of shock. Sometimes people with decompensated sepsis will have, buildup of toxic metabolites, and towards the tail end of their disease process, the EF will start to sort of fail out. Patients with normal echoes and patients with normal ejection fraction and patients with high ejection fraction, you think probably more volume loss or distributive shock, septic shock, those kinds of things. There was one study that looked at the sensitivity and specificity for a hyperdynamic EF as a way of identifying sepsis in a patient. And actually, the test characteristics were very good. In terms of the specificity, they had maybe 95% specificity for shock from sepsis when you had a hyperdynamic EF. Sensitivity wasn't as good, and so maybe 30% sensitive for that, but a good sort of initial salvo. Pericardial effusion. Obviously, this would be a sort of a slam dunk cause of shock. If you pericardial effusion and you see sign tamponade, or even signs of aortic root dilatation, which could suggest perhaps you have a dissection that's going back into the pericardium and causing tamponade. That could be pretty grim, but also super valuable at the bedside. Right heart strain. These are patients who have decompensated pulmonary hypertension or an acute event like a pulmonary embolism. So I think that this is really valuable. In our department, we've picked up several of these and managed with IV sort of thrombolytics at the bedside. And then valvular abnormality, looking for severe aortic stenosis, regurgitation, vegetations, and endocarditis cases. These could be source of acute cardiopulmonary sort of collapse. One of the classic being the papillary muscle rupture that leads to severe mitral valve regurgitation and decompensation. So that's pump. For tank, you're looking at the sort of volume here. So the first thing I go to is IVC. Are we talking about a thick IVC, a plethoric IVC that's stiff and non-variable, or that thin kind of kissing IVC that suggests probably decreased volume? A thick IVC that doesn't vary in a patient who's hemodynamically unstable would suggest some kind of obstructive shock, heart failure, pulmonary embolism, tension pneumothorax, tamponade, one of these kinds of diseases. And I think the IVC, if I could just have one test, if I could just look at one thing with ultrasound in a patient who's sick in front of me crashing, I think it would probably be the IVC, just because it very quickly differentiates between the hypovolemic or distributive shock patient and one who's got more obstructive etiology of shock. And the treatment pathways for those two types of disease are so different. You'd resuscitate the with fluid that's thin and sort of very variable IVC, or the thick and stiff IVC might need a more targeted intervention like a pericardiocentesis or maybe a chest tube if you have a big tension pneumothorax. The thoracic part of the tank assessment, basically you're looking for fluid where it doesn't belong. So pulmonary edema characterized by B lines, unilateral, bilateral, pleural effusions, again, fluid where it doesn't belong in the chest. And then the fast exam, obviously free fluid in the abdomen. So you're looking for sort of a leaky tank, they call it. All right, now the pipes part of this, I guess the big one is the aortic catastrophe, right? So the big red, if you have a thoracic or abdominal aorta that's aneurysmal or showing signs of dissection, that could certainly be the cause of your acute hemodynamic decompensation. We've had a few of those that I've been attending for in the ED. And what's required in these cases, obviously, is surgical. But if you get this answer very quickly, you can get your colleague on board, thoracic surgeon or cardiothoracic vascular. The other part of the pipes assessment is to look at the deep veins. If you have a patient who's crashing in front of you and maybe they're busy with the chest while they're sort of preparing for the resuscitation. If you have the right clinical setting and you look for DVT in lower extremities, you could have an answer pretty quick. If you have what appears to be an acute DVT in lower extremity, this could be thromboembolic. So that's the sort of general idea. Here's the infographic. We go pump, tank, pipes. And that's basically the whole idea. It's a study that incorporates your knowledge of the other body systems and sort of asks you to maybe algorithmically run through your causes of shock by using what you've already learned. So if you'll humor me, I have a couple practice cases. And since it's just you, my man, we'll just do as many cases as you like. I think I have like 6 or 7 of them. But the idea is that you have a patient in front of you who's very undifferentiated. You don't even have a chief complaint. You don't know the HBI. They're trying to get vital signs, but because of how sick he is, maybe the vital signs aren't reading. He's not getting a good blood pressure. The pulse ox isn't reading. You don't know his past medical history. And in terms of a physical exam, it's just one of these very sick, sort of pericode appearing patients. He's pale, distressed, difficult to palpate central pulses. And you have an ultrasound, but you do have an ultrasound. And so this person's going to need some kind of acute intervention, and you have options. And I don't like the idea of being pedantic. I think that you can start with any study that you like, especially if you have like a hunch. So what would you like to ultrasound first? You say what you want, and I'll give you a representative ultrasound of that system for this particular patient.
I think we can go heart first.
You want to start with the heart?
Yeah, I guess, yeah.
Yeah, let's go. Okay, so heart. All right, so yeah, hyperdynamic, right? Exactly. So you put it on the probe. You put the probe in his heart. He's hyperdynamic, and so I guess that's super valuable in this case. I think also there's no evidence, I think, of right heart strain here. So you're thinking some kind of volume loss, some kind of distributive shock right off the bat.
Yep. The volume loss here. Can we look into IVC then next?
Let's do it. Yeah, I think that this is like a pretty nice image of an IVC. So here's the IVC in long axis, if you can't see
That's right.
Yeah, exactly. Yeah. So this sort of also goes along with the initial impression that you got from the echocardiogram. We have a very flat And now you don't know this patient from anybody, middle-aged guy, hypotensive. See if you can anything else you want to look at.
So what? So we have to choose next then, or
Yeah, just which one you want to do next?
we can do fast exam probably.
All right, yeah, do it fast. I'll just give you. I think I just have the one picture for a fast. So if you think it's negative, then we'll just call it a negative fast.
Look like
We
negative
have
though, right?
negative fast, yeah.
So probably we can go to maybe aorta or
Sure.
like
Here's his aorta.
it's like bigger, thicker. I think it's like
Oh yeah.
dilated, right?
Yeah, so
Yes,
exactly. So
flap.
this would be sort of considered an aneurysmal aorta. He has
Mm.
some what you would call clot inhomogeneity, where the clot is not uniform throughout. There's these areas where it's bright, but areas also where it's anechoic, and he has areas of para-aortic, well, fluid, free fluid, it's anechoic. So he likely, I would think, based on this vignette, you'd also see a little interruption in the wall here. So this is a case of somebody with a ruptured AAA.
Mm.
As the etiology. So, I mean, at least this is a bad disease and, a tough morbidity, mortality. But I think, it's very reasonable to think that within maybe a minute and 30 seconds or 2 minutes of you scanning him, you did it in a
Mm-hmm.
systematic way. You already identified the cause of his decompensation. And so as you get IV access and sort of do those other things, you already know what you're dealing with, which is what we love this exam for. So that's that guy. What we do a few more of these. So young woman, and you're told the chief complaint was something about dizziness, although it's not totally clear because she was very sick. The past medical, again, vital signs, surgical, we don't know any of these things about her. And she just looks very sick again, obtunded, pale, dyspneic, really kind of a pericode appearing woman. And so you get your team on the patient, getting IV access, maybe putting her on a non-rebreather, and you have your options laid out in front of you again.
We can start with maybe lungs.
Sure. So this is a representative image. This is a linear probe. We have the lung, sort of beautiful picture, I think, rib, and the pleural line. What do you think?
He has some. I don't think he has. He has
Yeah, it looks pretty good, right? I mean,
B
there's
lines. No B line.
good sliding. I mean, there's like maybe one comet tail over on this side, but I wouldn't call like a heavy B line really. B lines would be pretty bright, and they would all go down to the far field. You've got a nice A line down here, so it's a good. I think it's a really valuable thing to look at somebody's chest, particularly because we said in the vignette that she appeared dyspneic. But this looks like a pretty good, and we'll take this as representative. This looks like a pretty good sort of thoracic picture. What would be good next?
The next one we can see probably heart.
Sure, heart, yeah. Yeah,
Like
this was
look
a
like
case.
low EF, right?
Well, there's definitely something abnormal going on here. So I think this requires a little orientation. It's a little bit of it's slightly off axis, but it's a parasternal short axis view, right? And so we're actually cutting the left ventricle in its short axis, with a little bit of like a rotation here. But the thing that jumps out here is this: we haven't seen, I don't think, scanning too many of these cases, but the flattening of the interventricular septum down towards the left ventricle and the
Mm-hmm.
size of the right ventricle here. And so this was a case that I had. This is somebody with what turned out to be a pulmonary embolism causing acute
Oh yeah.
decompensation. Right. So this is like, and this is one of these cases where it's a very quick thing to find this. And you can see, okay, there is right heart strain. We don't know this woman from before. So sometimes people with chronic pulmonary hypertension can have dilated right heart, and maybe she became hypoxic. And so the pressure went up a bit, and this has become more decompensated. And so I think my next move here would be to take a quick look. Well, let me just see if she got a DVT. And if
Mm.
you're compressing down here, clot right here, you see that? They're compressing. Here's the artery. They're compressing the vein, and there's no
Mm-hmm.
collapse. I think the combination of those two things, for me and somebody who's acutely decompensated, even if you don't have much history, boy,
Mm-hmm.
that's that's pretty slammed. I mean, there's other sort of echocardiographic measurements you could take, but to keep things simple, in the standard views that we're comfortable with, like this personal short axis view we had, there's obviously right heart strain. There's what they call the D sign, where the septum's getting pushed over, and then plus this image of the DVT. I think I'd be pretty confident in diagnosing and treating, pulmonary embolism as the cause of the
Embolism,
decompensation.
yeah,
Yeah.
definitely.
All right, could do a few more of these if you'll humor me. So we have an older woman. I'm not going to give you much on any of these. The chief complaint was that she's breathing fast. Well, again, we don't know vitals, history, HPI, and she's very ill appearing. She's an older woman. She got a thready pulse. She's diaphoretic and pale. So again, very minimal that you can get initially from your exam. You're rushing to get her on the monitor. What do we want from this young lady, this
Like we
older
can
lady?
go to heart first, I guess. Look like
Do it. This is a
yeah,
kind of
this OEF.
yeah. EF is definitely a little abnormal here. One thing that jumps out to me with this is that her septum is a little hypokinetic, certainly,
Mm,
right? It's like the lateral wall and the apex are doing a lot of the squeezing, and the septum is just sort of it's getting moved around, but it doesn't appear to be contracting. And maybe her left atrium's a little large. This could be acute, certainly, and you could have somebody who maybe he's just infarcted her septum. However, like
mm,
the natural sort of history of acute coronary syndrome is really not to drop your blood pressure unless your EF is really lousy. You have this dilated cardiomyopathy. More that they would decompensate from an arrhythmia, VT, VF. So she definitely has this. And the question, this is a real case. This is a kind of complex case. The question that we had here was, oh, does this patient have a chronic septal infarct? And then we're not really identifying yet the cause. So we had to keep
mm.
scanning around. Uh,
Maybe lungs that she can have
yeah,
a
sure.
pulmonary edema.
Yeah, so this one was a pretty compelling lung ultrasound. So what do you make of this, Hafsa? What do you got here? These are so up here's the ribs. You've got this sort of bright pleural line.
Is pneumonia there or something?
Yeah, man, absolutely, 100%. Because there's this the subpleural consolidation. You can sort of see that
Yeah.
echo texture looks almost a little liver-like, and then you have some heavy B lines when it starts to mix with fluid. You even have a little a little pleural effusion here, a little sort of that anechoic area. So moving kind of quick, a little anechoic area. So maybe exudative effusion as well. So then we have okay. So she's got actually there's maybe one more of these. We go down to the base of the lung on that side. We see. Can you see this here? We got the diaphragm here. There's this
Mm,
area here of effusion, right? You see that nice wedge of anechoic sort of fluid there. So she has
mm,
pneumonia, some effusion there above the diaphragm.
yeah.
Um, And actually, the other side, it's the same story. So it's kind of bad looking lungs on both sides. Consolidation looks like probably bilateral pneumonia, we'll say. So this was sort of an interesting case. Let me show you her fast. Went down to the belly to do a fast exam, see what was going on there. And all we ran into was difficult time getting our sort of classic views, but what really drew our eye was these dilated loops of bowel with this
Mm,
reverse peristalsis. And you see how dilated this is. You could put calipers across this. The magic number is 2.5, but she was much more than that. So this was a case of a woman who had at home, we think infarcted her bowel, maybe from this is kind of complicated. So from having this infarct in her heart, I'm not sure how old that was. She maybe developed a thrombus and infarcted her bowel. And when she infarcted her
okay,
bowel,
okay.
it became dilated and she vomited and aspirated. And so she developed this pneumonia. And so she really had like,
Mm,
you kind of start putting together this whole picture with this poor lady. She had multi-organ dysfunction as a result of probably the initial insult was the cardiac, leading to thrombus, leading to embolization, leading to this gut, immotility, a sort of obstruction picture. But really, this was a dead gut, unfortunately. And then she developed a pneumonia, and other organ systems sort of went along with that. I'm not sure this was exactly her, but this is representative, somebody with a flat IVC. So very sick lady. But I think you can tell just scanning around through this rush protocol, you get quite a bit of information really quick, especially if you get to start to put together a little bit of the history. If you're given a little more than I'm giving you here, uh, we have another middle-aged guy again, sort of similar sort of vignette. And then what do you want to do with this guy? These are all going to be different, I think, sources of the decompensation.
Mm. Let's start with the heart again.
Yeah, I think that's the right instinct, and I think I probably would too. And when I talk about the IVC being my favorite, I sort of include well, they have it separate in this protocol, but when I'm doing the heart, I include IVC kind of as part of the heart assessment. So okay, so here we go. A few things jumping out here. What's your read on this here?
Mm, no pleural effusion, sorry, pericardial effusion though. Like low EF look like to me.
Agreed. Yeah, he's got definitely some dilated cardiomyopathy. You could see, the trademarks of the low EF is that the fractional shortening is decreased. In other words, the change in the chamber
Mm.
size, systole to diastole, is decreased. The movement of the anterior leaflet of the mitral valve isn't very robust. It's not coming
Mm.
close, really to touching the septum, and there isn't very good vertical movement, what we call like longitudinal movement of the annulus of the mitral valve. So indications of bad EF. The aortic valve looks like it's opening okay. And then
Mm.
I would say there's like maybe a trivial pericardial effusion, tiny,
Yeah, look like thin layer there, but it's
yeah,
not that significant.
not enough to cause a trouble. And then on the other side of the pericardium, though, on the other side of the maybe in the chest is a maybe indication of some pleural effusion. So we could drill back down into that. But also the aortic root size
Mm.
appears relatively normal. So I don't think right off the bat I'm not thinking aortic, at least thoracic aortic aneurysm or thoracic aortic dissection. So that's the initial sort of salvo. So decreased EF. I mean, certainly somebody can have a decompensated cardiogenic shock.
Absolutely.
Yeah, yeah, for sure. What do you want to look at next?
IVC.
Yeah. Okay. So as part of that cardiac, you do the IVC, and you see again. So here's the IVC here. It's
Yeah, it's pretty dilated, right?
it is, yeah. It's dilated. It's stiff. It doesn't it doesn't vary much with respiration. You even see some dilation, I think, of the hepatic vein reaching down towards it. Sometimes when you have like this sort of dilated, you get a little smokiness to the flow because there's a little bit slower flow of the blood. And you can also see, sort of hard to nail down, but there's a little fluid here where it doesn't belong, probably in the chest again, indication of a pleural effusion. So, I mean, with this case, dilated IVC, poor EF, decompensated gentleman. We'll take a peek at the lungs. I'm always curious to take a look. Oop, and there's the pleural effusion for sure.
Pleural effusion too, yeah.
Yeah, so he's got fluid in the lungs. I think there's some B lines on that last one. Yeah, big time. So bilateral, we'll call bilateral pleural effusions, bilateral B lines, decreased EF, plethoric, stiff, non-varying IVC. So this is probably like a decompensated. We'll call this like a decompensated heart failure. So fluid's probably not the thing to do for this guy. Maybe you'd add some inotropes on. Depending on the whole sort of clinical picture, you may need to do dobutamine. You may need to call cardiology for help in this case. Young woman. Not really clear what her history is. She came in, it's just in distress, diaphoretic pormentation. I've had a few cases just like this, and the ultimate diagnosis is somewhat common in the ER. So, where do you want to go with her?
We can do fast again first.
Yeah, smart. And here's a representative image for this young lady. So, we just to kind of orient you. It's tough to just to drop you in, but you have the uterus here and cutting cross section. Her bladder was pretty empty. But what do you what's jumping out at you here? I think probably is
Like fluid around there.
exactly, yeah, free fluid in the abdomen. And this is exactly, and I've had this exact kind of case, and I've done the exact thing that you did. And then the next thing I want is a pregnancy test. I'm kind of a little bit at this point done with the ultrasound. I say, oh, we have an unstable young woman, uh, fluid in her belly. You know, odds are this could be the blood. So is this a ruptured ectopic? And that's what we did in this
Mm.
case. That's a quick way to get to the diagnosis. The next one, elderly gentleman. Again, I'm not going to give you much here. So what you want to take a look at?
Italy, man, we can look into heart first. Heart.
Let's do it. All right. So actually, I'm not trying to mess with you here, but this is the cardiac orientation. And so just to kind of orient you here, on the left is the left
Aorta is dilated, right?
Exactly. You're all over it. The aorta is dilated, and even if you watch it through the cardiac cycle, there's something about it. And I've had cases just like this a few times. Do you see during diastole, there's this sort of flap that sort of reaches down from the aorta there, right there. That sort of curvilinear structure that comes across. So this person is also it's wide. So it's aneurysmal, but it also appears based on this to be dissected. And
Mm-hmm.
one thing that we could do, we probably haven't done this very much, but when you have a dissection and you see it obviously here, or at least you strongly suspect that you see it, you can take the
Mm-hmm.
probe and place it in the suprasternal notch and angle it down to catch the arch of the aorta, like they have
Mm-hmm.
here. So you have the sort of this ascending aorta here, the descending here. You have those three branches, brachiocephalic. Um, and you can see clear as day here. You got this nice dissection flap. So this is a type A dissection. And this diagnosis took you 20 seconds. And so this is cardiothoracic surgery. As Malal, the whole bit. All right. Next one. Elderly woman. I'm not giving you much here. Elderly woman. What do you want on her? I think you're liking the heart.
Heart, yeah.
Let's go. So here's a representative image. It's cardiac orientation, so a little backwards appearing from what we're used to, but you have the liver in the near field and you have the heart here in the far field. And so,
See clearly.
nothing really jumping out too much, right? Are you getting anything big here? Here's the left ventricle here, right
Mm-hmm.
ventricle here. Nothing really, right? Maybe hyperdynamic would be a good
Lungs,
guess.
man.
Yeah. Well, there you go.
Yeah,
So you got
B-lines.
well, perhaps there's like some vertical
No.
change coming off, but there's, if she's trying to breathe and the pleural line looks like
Mm.
this is somebody where you could drop an M mode across this, and instead of getting the sandy beach, you get that stratosphere sign. No sliding, no lung sliding.
Mm.
And so perhaps a patient with chronic obstructive pulmonary disease, maybe she had a bleb that ruptured, whatever it was, spontaneous pneumothorax, and she's now decompensated. And so this is a case of tension pneumothorax.
Mm.
You could see here. Well, maybe the next thing you do if you had a moment is you would slide down and around and look and see if you can find the lung point. But I think for this case, pretty compelling looking thing. I probably check both sides, confirm I have sliding on the other side. But yeah, this probably requires a. Let me see if we have the lung point. There it is. So you get a
Mm.
pleural space, and when she breathes in, you get a little bit of lung sneaks in, and then it goes away again. So this is
Mm.
and
Definitely.
yeah, that's really the idea with this exam. I think this is the last one. Elderly man, thin, pale, distressed. We'll go with his heart. And if you won't go wrong, I think looking at somebody in
Yes,
shock.
this is pericardial vein, yeah.
Oh yeah, so that's this, yeah. And so this needs a pericardiocentesis, and you're already basically have your diagnosis. Everything else is going to be uh, sort of ancillary to getting this dealt with. This patient's decompensating acutely from rather large pericardial effusion. Very good. All right, man. Well, I think we'll stop it there. Did you have any questions about that, or
No, good. Yeah.
cool, right? Kind of a cool study, a cool, I think, way to frame decompensated, um, acute sort of decompensation. And I think the more that we get these scans, the more you're going to build confidence in doing
Mm.
this quickly the bedside.
Yeah.
All right, brother.
Perfect. Thanks so much.
All right, man. Talk to you later.